Hello. I'd like to introduce you to some colleagues and friends of mine. Bertie Lee, who is an EACTS lawyer and in England specializes in medical negligence, and Jose Pomar, of course, past president of the EACTS. And we're here just to talk a little bit about candor and the duty of candor. Just to give you an example of the meaning to me, if I ask my 19-year-old son to go down on Sunday to get a special edition of Motorsport from the local newsagent, he comes back, he gives me the magazine, but he fails to mention that he scratched the front wing of the car. He's failed to be completely candid with me. So, Bertie, how do you think we're going to use the duty of candor? How are we going to integrate that into our medical practice?
Well, I think the duty of candor recognizes the fact that medicine has changed completely over the last 80 years. It used to start off when the outcomes of medicine were unknown and we only submitted to surgery because we had virtually no alternative, and we thought we were extremely lucky if we survived. Now it's become much more of a service, and the relationship between the doctor and the patient has changed, whereas I used to put myself in your hands and say, do with me as you will, and hope I survive. Now, I expect you to teach me. I expect you to explain the world to me. I know that if you're treating my cardiac disease, you can only do certain things for me. You can change a blocked vessel. But if I'm going to live for another 30 years, I have got to change my whole behavior and the way I live my life, and I depend on you for that advice. And it may be that surgery is not the best option for treating my disease, and it's you who has to explain that to me. Now, if we understand that the doctor is in fact a teacher, as well as being a clinician and a technician, if we understand that what he does in public health as an advocate in society is just important as what he does as an individual technician, then we realize the whole relationship has changed. And this goes all the way through. If you have a complication when you're operating on me, if something goes wrong, then I expect you to tell me about it. If you discover something about my body that was not known before, you had one priceless opportunity of finding that out when you were inside my chest. And if you don't share that information with me, then you haven't done as well as you can for me. Now, if in fact you have a complication, if in fact you've done something wrong, you've made a mistake, it doesn't matter whether it's a question of compensation or not. If I have suffered as a result of something that you have done, and you don't tell me and explain things to me, then the relationship is flawed. How can I trust you as my guide and teacher if in fact you're concealing things from me? And your example of your son with your car, I hope you don't lend it to him very often, by the way, it seems to me to be a very good example. There is a risk that he will scratch the wing of your car every time you lend it to him. And if you want to get Motorsport every weekend brought to your chair sitting in your sitting room without having to risk scratching the wing of your car yourself, you have to lend it to him. And it's exactly the same as me when I have to submit my body to your care. But it doesn't mean to say that you have a license to conceal things. Now, we've had a series of scandals in England, as a result of which we're now introducing a statutory duty of candor, which is coming in very soon. The regulations are already before Parliament. And in certain circumstances, there are going to be criminal penalties, not directly and simply for failing to be candid, but if you lie to me or mislead me deliberately, or if you tell a colleague not to be candid with me to cover things up, then there will be criminal penalties. The duty is imposed in England on the institution rather than the individual doctor. And it's the employing institution that has the duty of candor and has to explain things to the patient. We've had it for some time as a contractual duty between those who commission care on behalf of the state and those who provide it. And if they fail to be candid with the patient under the contract, they will get fined. The money doesn't go to the patient. It's rather an odd arrangement. But the whole of the money that the state, one arm of the state, would have paid to the hospital for carrying out the operation is forfeit and paid back to the commissioning body. So if you are not candid with me, one bit of the NHS pays another bit some money. You may think this is a rather strange arrangement. Certainly quite a lot of us do. It doesn't seem to be very cogent as far as either the doctor or the patient is concerned, but it does at least show that we recognise that it's important and that we want you to be our guides and mentors.
I think to some extent we're already doing that in clinical trials.
Yes.
When we invite a patient to partake in a clinical trial, it's always difficult because the patient wants to feel secure, taken into a metaphorical womb and looked after, and doesn't want to hear that you actually don't know the difference between treatment A and treatment B. So you have to explain it in a more mature way than that. In Spain, are you going through a similar transition?
Well, I think so. I think it's everywhere, but it's in every country maybe a little bit different. But we are more and more working as a heart team. You were mentioning that the surgeon who is doing an operation which is maybe not necessary and can be treated with a drug or whatever, we have been suffering that because for years we thought coronary surgery was better than other procedures and we could not say anything. So how in the heart team is going to be shared the responsibilities, or is it going to be the institution? How do you think it's going to be that?
Well, the duty of candor, the statutory duty of candor, is to deal with complications when things have gone wrong.
But you can say you prefer not to have the complication. You want
yes,
to,
but if something has gone wrong,
prophylactic.
then everybody has a duty to be candid, and the statutory duty in England falls on the institution. So the medical director of the hospital has a duty to explain to the patient that things have gone wrong and to apologise on behalf of the institution. And that's a fairly formulaic, formal bureaucratic process. But I think of it in a different way. I think that everybody has a duty to be candid with the patient. I think that when you talk about the cardiac team, you have to recognise the most important member of the team is the patient.
And no doubt.
Ultimately, the patient has to take the decision, and the patient depends upon you and the cardiologist and everyone else to be candid in preparing them to take that decision. And it starts before the operation and goes right the way through. We have, as patients, I'm afraid, tended to try to abandon our own responsibilities, and we have been the principal conspirators in this process of saying, I don't want to know. I want to leave it. John Pepper, he's a great surgeon, let's leave him to take the decisions for me. He can't do that. He's not me. He has different priorities, different senses. Mm-hmm. I remember in a different context, I did a case for a urology team about prostate cancer. And one of the young surgeons told me that every patient he counsels always says to him at some point, what would you do if you were in my position? And this chap who I was talking to, he's aged about 30, he said, we are all trained absolutely to duck that question. We cannot answer because we are living in a different period of our life. That function is of different importance to us. We have no idea how that patient sees their prostate functions and the complications that they're risking in undergoing that surgery. And it's exactly the same. We all have different priorities, different processes. You may know that you can heal me and promise me 30 years of healthy life if you can get me to change my diet and to take more exercise. But you don't know whether I'm prepared to do that. And if I'm not, you may think that a different decision would be appropriate for me.
I have a question. The has been always said, the bigger the volume load of a unit, the better the outcomes. This is typically written everywhere. The more operations you do, you will do that better. But you will probably not take care of the patient the same way. You will not be able to have the time to be candid with the patient, to explain the patient exactly what kinds of possibilities you have. So how do you balance that?
Well, if you're talking about larger operating volumes, then I think that what they are justified when they enable the relationship between one doctor and one patient to be more effective. If you get patients looking like cans of baked beans and they all go through the unit so that they can all have a cabbage fitted effectively in large numbers, that is not medicine, that is not treatment.
Yeah, it's becoming a factory.
It's
yes,
factory.
yes, I
the
do agree.
medicine is when the individual patient gets perfect optimal care for them. And it won't be the same for two patients who have the same films.
Can I just raise a different thing that's becoming more and more evident as we understand more about the genotype and the phenotype and so forth? We are increasingly doing operations on people who have no symptoms at all. Yes. So there's an enormous sense of trust. We say there's this big shadow inside your chest. And we've discovered that this is because your aorta is 3 times the size it should be. And it's going to rupture if we don't do something. Actually, we're not very sure of the natural history in truth. But nevertheless, we want you to undergo this operation. Actually, it's got a 8 or 10% mortality. So that is a new level of difficulty, absolutely, I think, in explaining. Absolutely. From a lawyer's point of view, or from a patient's point of view, if you were in that situation, there's an enormous degree of trust required. What would be your reaction?
Absolutely.
Well, I think I've had my aorta screened, and I think it's the one investigation that I would have. I don't know what my PSA is, but I know what the diameter of my aorta is, because I think that the natural history of that disease is such that can be managed effectively, and you have an opportunity of intervening with it. Whereas with PSAs, they now have a system of focused ultrasound where they are able to operate not to ablate the whole prostate gland, but just to hit the spot of the prostate which is causing the elevated Gleason. So you go to see them because you've got an elevated PSA. They operate on you, and all they have done is to bring down your PSA. They haven't changed the fundamental anatomy of the prostate gland. It's quite extraordinary. So if you are able to operate just to reduce the diameter of my aorta, I'd be very grateful, because the difference between the mortality of a dissecting aortic aneurysm and you doing a little endovascular job is so enormous. But you have to explain it to me, you have to talk to me, you have to say, I might be able to avoid this, Bertie, if you were prepared to change your diet or your habit or whatever. And you can give me that choice, and you put me in a position to take a more sophisticated level of decision making. Take another example. Take benign gynecology. This is all performed for symptoms. It doesn't save any lives. And these symptoms are all painful, embarrassing, humiliating. They're the reflection of the fact that the woman is getting older and is intolerant of that. All of those symptoms have in common one thing. They are experienced by the patient, and they are never experienced by the doctor. And yet, every patient who is presenting those symptoms, we know, is going to distort them, depending on her enthusiasm for the surgery. She may belittle them because she's frightened of surgeons. She may exaggerate them because she's intolerant of her own aging process and has high standards of her own physical appearance or behavior. Now, the same thing happens in a more subtle sense in cardiac surgery. Some of us are very anxious to carry on jogging and running, inexplicably in my way of thinking, but nonetheless, there are people who think it's terribly important they should be able to carry on running 3 miles a day into their 60s. Now, those people, again, have different attitudes to different interventions and to different things that you can do to help them. And your job is to put your knowledge at their disposal so that they can take a more sophisticated decision. It's not your decision.
Well, I think you've explained that extremely well.
Very well.
We haven't time to go into it further, but of course, the area of congenital heart disease is a huge minefield, and explaining to someone the long-term consequences of having your right ventricular outflow tract rearranged is another area. But Bertie, thank you very much, and Jose,
thank you very much.